Good afternoon, doctors. I am Rajesh Sharma from VJyoti, and VJyoti is a company based at Delhi, and we are dealing mainly with the patient blood management. And for this patient blood management, we have equipment which is called Rotem. This is an instrument which is a point of care instrument and can be used to reduce the blood transfusions. So before we'll go to Rotem, I'll have a small presentation which I request you to please go through this presentation. So the main issue is inappropriate blood transfusion, which we all agree that it increases the morbidity, mortality and the hospital cost also. There are several studies which confirms that. There is one from cardiovascular surgeries. The number of patients, more than 8,500 cardiac surgery patients, period 96 to 2003, which clearly says the moment you increase the transfusion, the gap between morbidity and mortality also increases. So the point is we have to transfuse as less as possible. Another study which is again on more than 1,25,000 patients, which says even if you give 1 unit of transfusion, it also has morbidity and mortality gap. So even 1 unit of blood is not safe. Now it is very important that in complicated situations, yes, we have to give blood. But in current scenarios, you will all agree that turnaround time is very important, because when patient bleeds, you have to give something. And currently in India, the situation is if we depend on the laboratory test, then the turnaround time is about 90 minutes. So that means in those 90 minutes, patient will continue to bleed and we will give blood transfusion as per our own experience. If we use the thromboelastography, which is another technique which is available, but that is also gives you results in 30 minutes. So that means again 30 minutes patient is going to bleed and you tend to give something to the patient. So we need a kind of a machine which can reduce this time, turnaround time, to as minimum as possible. So how to reduce this transfusion, what is right and what is wrong? And the answer is patient blood management. This PBM is being practiced internationally in most of the countries, and most of the countries, they have their guidelines also how to give transfusions to the patient. So for this PBM, there has to be a series of right. Right means right patient, right product, right reason and right time. Now it is very important to understand what is right means. Right is a clinical decision which is informed by evidence. Now it is important that who defines that right. In our case, it is definitely a point of care testing machine which defines that particular right thing. So while we determine the point of care machine, there are certain criteria on which you can select the machine. So the criteria are machine has to be fast, because we have seen that it has to give result very fast. It has to give detailed analysis, so that because these days nobody is using whole blood. We have different components of blood. So detailed analysis means it should pinpoint the deficiency, that what is the deficiency because of which patient is bleeding. Then it has to be reliable. It has to be user friendly so that anybody can use. Dependency on the technicians on any other thing should not be there, because bleeding can happen anytime. And it has to be very stable also. So if you get all these things, then focus definitely is to be on the patient and on the right blood product. So for this, internationally accepted patient blood management PBM is a multidisciplinary, timely application of evidence-based medical and surgical concepts designed to improve the patient outcome. This PBM actually works on 3 pillars. First pillar is maintaining the hemoglobin concentration. Second pillar is optimizing the hemostasis. And the third pillar is minimizing blood loss in an effort to improve the patient outcome. In fact, our machine, which is Rotem, works on this third pillar, minimizing the blood loss in an effort to improve patient outcome. Because if we minimize the patient blood loss, then actually we are utilizing the patient's own blood to improve his condition. This is Rotem, which has 4 channels, viscoelastic testing. It also does the platelet aggregation test, platelet functionality test, platelet aggregometer. This upper part is platelet. And these are the 4 channels for viscoelastic test. This machine is approved by US FDA. Machine is approved by CE, European authorities and Canada Health also. I'll just go through the basic principle of the machine. There is a cup and a pin, cup which is rotating and pin is on a torsion wire, and we add the reagents and there is a graph which it forms. This is the principle of Rotem. In Rotem we have reversed the situation because here the cup is fixed and pin is rotating on a ball bearing, so that makes the system very stable. And how it gives you results, that we'll see in next few slides. But before going to this, just we understand how the coagulation cascade actually works. There is an extrinsic pathway and intrinsic pathway, we all know the textbook version. Tissue factor which activates the extrinsic pathway, it activates factor 7 to 7A. Then there is an intrinsic pathway, factor 12, 9, 11, 10, and prothrombin, thrombin and fibrin. Finally fibrin, thrombin generation. And the recent finding says that tissue factor does not activate only factor 7A, it also activates factor 9 and factor 10. And once it activates factor 10A, then the role of extrinsic pathway stops. And it also implies that the in the coagulation, main factors which are responsible are these only. So the new protein which is called tissue factor pathway inhibitor blocks the further action of tissue factor, factor 7A. And it offers three major steps. One is called initiation, one is called amplification, and third is propagation. Initiation, when tissue factor activates factor 7 to 7A, amplification, then when we have a lot of tinase and prothrombin complex formation, and propagation, finally the fibrin formation. So this is one part of the coagulation where we have the fibrin formation. And on the other part, there is a platelet aggregation which is also going on side by side. So we'll also see the platelet aggregation. There are different pathways, and once any injury happens, secondary platelet aggregation takes place in just 5 minutes. Platelet aggregates, it changes its shapes, and it binds together. And these are the activated platelets. These are the recepting sites where fibrinogen attaches. And if in cardiology especially, if patient is on antiplatelet therapies, then these sites are blocked so that the active platelets are not available for coagulation. So this machine also does this also, if your patient is on antiplatelet therapy, it will tells you that how many functional platelets are available for the action. And if you have stopped giving antiplatelet therapy, it will also tell that whether the drug has stopped working or not.
If there is a distraction of the platelet, then also it will get, suppose on the bypass, where you have a distraction of the platelet, shape changes in the shape, or platelets degradation has taken place, then also it will say.
Sir, it will say only if platelets are blocked because of the drug, not because of anything else, only because of the drug. And for drugs, we have specific reagents, like for arachidonic acid pathway, we have Rotem, which will give you the aspirin. Similarly, for adenosine diphosphate, for clopidogrel, and for eptifibatide, we have the TRAP. It is only the drug specific. And this we all know that yes, it blocks the sites. This is the platelet adhesion and the general platelets and fibrin and a clot. Now this is the working of the platelet aggregometry. There are 2 electrodes. These 2 electrodes, we add the blood and the activator in this, current passes, and once the current passes, we add the blood, these platelets tend to form around the electrodes, and there is an impedance resistance, and because of that resistance, there is a graph which is being formed. Now this is the kind of graph this platelet aggregation will form. Now there are 2 different graphs, one we have seen for viscoelastic testing and one we have seen for the platelet. Now first I'll go for the viscoelastic testing graphs. This is the kind of graph for viscoelastic testing. The first line, this is a small line, this is clotting time, CT time. It tells you the coagulation factor, anticoagulants, FDPs and tissue factor expressions. So that means if in any patient my clotting time is prolonged, that means initiation is not taking place, patient is having some factor deficiency. Now the second part is the clot formation time. This is small magenta part. After this line you see a small magenta part. This is called CFT, clot formation time. And then we see amplitudes after 5 minutes and amplitude after 10 minutes time. So these will tell me the platelet fibrinogen status, and then after this we have the maximum clot firmness and the lysis. This is the kind of graph we'll get for every viscoelastic testing. Now what are the different activators which we use to detect this? We have 4 different activators. First activator is called XTEM. Actually, the name of the company is TEM International. So that is why everything revolves around TEM. The machine is Rotem. Our activators are XTEM. XTEM name itself suggests extrinsic pathway. So extrinsic pathway, what we are adding in XTEM is tissue factor. Our activator is tissue factor, which is very much physiological. Because right from the beginning I am saying you have to act fast. This machine gives you results very fast. This is the reason, because we are using the physiological thing, which is tissue factor. So that means the same amount of time it will take which the patient body will take. Then we have another activator which is called FibTem. Again, as name itself suggests, fibrinogen, FibTem. This will give me the fibrinogen values. This XTEM, extrinsic pathway, will give me both the things, platelet and fibrinogen. Now I want to evaluate it is even platelet or fibrinogen, so I have FibTem. What we are doing in FibTem, we are adding first the tissue factor, which is XTEM, and cytochalasin D. This cytochalasin D is a very strong platelet inhibitor. So basically what I am doing in this test, this is just like XTEM, but I am just eliminating the platelets from this. So only this type of graph will come. This machine actually works on elimination principle. Now for hyperfibrinolysis, this machine has a test called APTEM, which is actually with tranexamic acid. So you can check the hyperfibrinolysis by doing APTEM test. Next test is for intrinsic pathway, as name itself suggests, INTEM. Here the activator is ellagic acid, and especially in cardiac setting, this will also give me the heparin influence in the patient. Now if patient is on heparin, his clotting time definitely will prolong, and to check whether this prolongation is because of heparin or because of clotting factors, we have another confirmatory test which is called HepTem. This HepTem is with lyophilized heparinase. So if the reversal of heparin has happened, then the CT correction will be there in HepTem test. These are the normal tomograms for the patient. If patient is not having any coagulopathy, any deficiency, this is the kind of XTEM graph which patient will have. This is the FibTem graph, normal FibTem graph, normal INTEM and APTEM. Now we have some abnormalities. This is a bleeding patient. Now you see XTEM amplitude decreases. And whenever we read any graph, first we see the CT and CFT values, then we go to amplitude. Because if my CT and CFT, they are in normal range, so that means we can assume that initiation has taken place, there is no deficiency of factors, it is platelets or fibrinogen deficiencies. So once we see here, it is normal CT, normal CFT, amplitudes are less. So that means either it is platelet deficiency or fibrinogen deficiency. Then I do the FibTem test. This is my normal FibTem. So that means fibrinogen levels are normal. Patient is bleeding because of the platelet deficiency. Now I just reverse the situation. You see this is XTEM, again less amplitude, but here you see FibTem is also very less. So here I assume platelets are fine, patient is bleeding because of the fibrinogen deficiency. So I can give cryoprecipitate or FFP. But again, yes, first we have to always see the CT and CFT values for factors, then go to platelet and fibrinogen for the amplitudes of A5 and A10 values. Hyperfibrinolysis case, clear-cut case, you see the lysis happening, but the moment I do the APTEM test, which is with tranexamic acid, you see the correction. There is no lysis here. So that means I can check even the hyperfibrinolysis with this machine. So this is about viscoelastic testing. Now I move to the platelet aggregometry. As I told you, we have three different assays. One is called ARATEM for arachidonic acid, which will give me aspirin effect. Then we have TRAP, thrombin activating peptide. This will give me the effect for drugs like aptifebatide. Then we have adenosine diphosphate, which will give me the result for clopidogrel. And here this is the kind of graph which we can see. This will take place, this graph, the total timing, it will take about 6 minutes. And the parameters which we'll see here is amplitude at 6 minutes. This amplitude, it describes how well the platelet aggregates after selective activation, maximum slope and area under the curve. Now this is a normal patient, all the three graphs are normal. If it is blocked by aspirin, Rotem is this graph flat falls, and this is for clopidogrel, dual antiplatelet therapy, severe thrombocytopenia case. So we can just see if patient is on antiplatelet therapy, whether they are responders, clopidogrel responders or non-responders, aspirin responders or non-responders. So this will give a complete picture of a bleeding patient. Now I'll take you to some of the published articles and references. This is again from Thoracic Surgeon 2003. Major bleeding is per se a risk factor for operative mortality, and adequate preemptive and treatment strategy should be applied to limit this event. And they see major bleeding and non-operative mortality reduced, ICU stay reduced, chances of stroke reduced, sepsis reduced. Now this is another study published in Anesthesiology 2011, done in more than 3,865 patients, which also says they compared pre-Rotem and post-Rotem scenario, 2004 and 2009 scenario. You see blood products have gone down, PRBC gone down, FFP gone down, platelets slightly increased. Again, fibrinogen role has gone up, because generally without this machine you tend to give the whole blood or everything to the patient. But with the help of this machine, you select the component which actually patient requires. And overall, if you see, massive transfusion has gone down, re-exploration again in CTVS cases, it can reduce, and there is no composite adverse effect. This is another interesting study which was done in Canada, done by Karkuti. They have compared again pre-Rotem and post-Rotem scenario in cardiac patients, and they compared 10 months data. And you'll be surprised to know that in 10 months time, they have reduced blood products up to the tune of 1.7 million Canadian dollar with Rotem. This does not include the cost of morbidity, hospital stay or anything else. Only on blood products they reduce. So the aim of this machine is to give minimum blood as possible as you can. And within 5 to 10 minutes, this machine will be able to tell you. This is another article published in Platelets, which clearly says that patients with thrombocytopenia but no major platelet dysfunction have a relative risk of receiving platelet concentrates of 2.5. This value goes to 6.8 with platelet dysfunction, and if it is both, then it is 9. Finally, anesthesiology, they also say in the 2015, they advocate the use of transfusion algorithms, especially those based on thromboelastographic testing to reduce the blood transfusion. Because before that, anesthesiology never confirms the role of thromboelastography in reducing the blood transfusion. First time in 2015, they clearly mentioned the role of these machines. Now, when you use this machine, then definitely you have to have certain kind of algorithms, because otherwise it is very difficult. It seems very complex. How to interpret it, what is this, what is that. So just to make life very simple, there are certain algorithms which are internationally approved algorithms which you can have and which you can follow also. So first is definitely the clinical situation. Second, you can check for hyperfibrinolysis. Then you can check, this is for CTVS. Then you can of course check for heparin and protamine management. Then you can check for clot firmness. Then you can check for thrombin generation, and then you can again reassess the clinical situation. I'll quickly go through one by one. Hyperfibrinolysis, yes, there are values. Currently, I know it looks little complex to you, but once you start using it, looks very simple. A5 amplitude after 5 minutes of XTEM is less than 35, or clotting time of FibTEM is more than 600, give tranexamic acid to the patient first. This is how it will look graphically. You see, A5 is just 8, FibTEM is prolonged, give tranexamic acid immediately to the patient. And in fact, the reason for this colored graph is again this, because you don't have to look into the real values. You can see the graph from a distance and you can have a clear-cut idea that yes, what it could lead to, and you can take your decisions. For heparin protamine dose, again yes, CT of INTEM is increased. My reference range for INTEM CT is 240 seconds. And if patient is on heparin, you see it has gone up to 621 seconds. We have a test for lyophilized heparinase. We can check with Rotem. It has come down, you see, from 621 to 260 seconds. That means the complete reversal has not taken place. Need to give protamine to the patient. For clot firmness, yes, fibrinogen concentrate or cryoprecipitates you can give in bleeding patient. We have seen in the graph amplitude is less for XTEM, FibTEM you can see. And this is the classical example, a bleeding patient. A5 of XTEM is less than 30 mm. You see only 22 mm, A5. FibTEM is only 2 mm, whereas my reference range says it has to be 9 or 10 mm. So that means it is deficient by 8 to 9 mm. So target increase in FibTEM should be 8 mm, 50 milligram per kg body weight into 80 kg patient weight, 4 gram fibrinogen, alternative cryo or FFP can be given to the patient. And you see the FibTEM A5 value from 2 mm, it has gone up to 9 mm. But the important point is how much time does it take? It happens only in 34 minutes. Because that is the main advantage with this. Otherwise in 34 minutes, you don't have any idea what to give and what not to give. So here you are just giving this specific product to the patient and not transfusing inappropriate.
All tests will take 34 minutes.
Sir, this is the 34 minutes correction has happened. Generally we do actually these two tests only, XTEM and FibTEM. These two tests will give you the idea. And after just seeing the graph for 5 minutes, you can take the corrective measures. This is another example. Graph looks very solid because you have seen all the amplitudes are very good, but still patient is bleeding. Now another thing, if everything is normal, still patient is bleeding, first look for surgical bleed. If there is no surgical bleed, then you can again redo the test. But in this case, when we look closely, the CT time of XTEM is prolonged. My reference range is till 79 seconds. It is 119 seconds. That is why patient is bleeding. So as I say, if the CT is prolonged, so that means it is clear-cut a deficiency of factors. So again, 1500 IU prothrombin complex concentrate is given to the patient. Alternatively, you can give FFP to the patient. But again, time is very important. 119 seconds, 278 seconds, correction has happened. In how much time? Only 19 minutes. So that's how you can reduce the transfusions in the patients. Similarly for platelets also, if fibrinogen FibTEM values are normal, you can always give platelets to the patient. So now I'm just concluding that the general problems of blood products we all know are morbidity, mortality, infections, TRALI, TRACO, transfusion reaction, tumor growth, cost of course. Everything is there. And we all know the risk. When we look at this table, it seems that everything is under control. Because we have, yes, today HIV, we check for HIV, we check for hepatitis, we check for everything. So it looks that everything is under control, but actually it is not. Because you will all agree that medical science is ever evolving. You never know what will happen tomorrow. And this is one paper which says that even Alzheimer's can be transmitted through blood transfusion. So you never know what will happen tomorrow. The live example in front of us today is Mr. Bachchan, Mr. Amitabh Bachchan. He has mentioned in the recent episodes of KBC that how he suffered hepatitis B from blood transfusion. So now, if you allow me, I'll just run that 1 minute video for you so you can hear from his. So again, the message is this only: you never know what you are transfusing today, what it can lead to tomorrow. And this is possible only when, but yes, on the other hand, you have to save the life of the patient also. So the best possible option is transfuse as less as possible. And this can be happen only with the help of the latest devices like this. So this is a Rotem. In fact, this is very easy to use. This, as I told you, we have 4 different what you call activators, test. Within 5 minutes, it will form the graph. And within 5 minutes, you will be able to take the corrective action for the patient and give to the patient what it is actually required for the patient. So thank you very much. Any questions? Yeah.
What should be the time between sample drawn and the the sample should reach to this machine and how much period of time? Because it will be prolonged, the reaction time will be less.
See, two things. First, we always call this is a point of care machine. It has to be kept in the OT or ICU, first of all. That is the, and secondly, we always take blood sample in a site rated vial. So can be kept for long. But yes, for the best results, it has to be kept in the OT or in the ICU. The moment you take the sample, immediately you can run. There is no, what you call the wait period for the blood sample. Immediately you can run the sample.
That's what I know, because thromboelastography has to be done. The reaction time should be less as to interpret. जितनी जल्दी सैंपल लगाऊंगा उतना appropriate मेरे को reaction time मिलेगा, उतनी जल्दी मैं corrective measures ले सकता हूँ, क्योंकि extensive pathway वहीं से सारा.
How much time this takes? 10?
So 10, actually, as I told you, amplitude after 5 minutes and amplitude after 10 minutes can assess. All the major algorithms, they are based on amplitude after 5 minutes. So 1 minute you can say for running 2 tests, 5 minutes you will get the amplitude, 6 minutes you can take the action.
Pretty shorter time, even lesser than getting the blood from the...
Absolutely, yes. Otherwise, in more than 5 minutes it takes to...
RKMA, thromboelastography के अंदर वो होते हैं, उनको ही same इन्होंने
Right. Because they are in fact activators, they are using, they are taking time.
Reaction time, the kappa angle,
There you can see the graph and just find out.
that's it.
So their R time, actually the R time reference range is 8 minutes. Because they are using kaolin, they are not using the tissue factor. So again, even in thromboelastography, 30 minutes minimum it takes to actually, give something to the patient.
But the graphs are almost identical and everything is similar.
The only another difference is that from graph is just a line. So again, you have to little bit concentrate on that. This is absolutely colored thing. From a distance you can see. And another advantages of this machine is complete in itself. Why complete in itself? It has a touch screen monitor. It has a 500 GB hard disk. You can create user and number of users department wise, password protected. You can connect printer to this. Through LAN, you can connect to HIS, LIS system of the hospital. This has a barcode scanner. No need to write patient data. This has an electronic pipette. So no need to adjust volumes every time. All the volumes are already there in the system. You have to just follow the screen. So thank you very much.